It's 1 p.m. We'll get started. My name's Tony Lemke. Welcome everybody. I'm a GP in Austinville in northern New South Wales, where it's a balmy 18 degrees. And I'm Chair of Faculty at the Improvement Foundation. And we're joined today by a very special guest, Kim Devery. And Kim, I'll get you to introduce yourself, please.
Sure, thanks Tony. I work at Flinders University and I coordinate the palliative care higher degrees. So we teach doctors, nurses and allied health professionals all about palliative care and end-of-life care.
Thank you. So Kim, you've been working on end-of-life essentials, and as you say, you're at the Flinders University. We're going to be talking today, Kim, what's your broad brush of what we're going to be talking about today?
Yeah, so today we're going to be, if we can just have the next slide, that's right. We're going to be talking about how Australians die, and we're going to be talking about how to identify the end of life. So that might be 1 or 2 years before somebody dies. How do, the core things that we need to keep uppermost in our mind when we communicate end-of-life issues with patients, goals of care, and then lastly, I'm really happy to pass on some quality, freely accessible and evidence-based resources.
Fantastic, Kim. And you've been working at Flinders and also in cooperation with the Australian Commission for Safety and Quality in Healthcare.
That's right. So the Australian Commission has done a lot of work in this space in end-of-life care, specifically in acute hospitals, but they did a lot of work with a background paper and interviewed consumers, patients, carers, doctors, nurses, allied health professionals about what was needed to improve end-of-life care. And out of that came some consensus guidelines, and we've flipped those over and developed education.
Fantastic. And part of those consensus guidelines included 5 important elements that we need to,
that's right,
skills we need to have to improve.
So if we're wondering about how to improve to deliver quality care, it's these core things were identified. So excellent communication, not being shy about talking about end-of-life issues, recognising dying, negotiating goals of care with a patient, which can be quite challenging, know how to act when things aren't going well, because suffering can happen throughout all of life, but it can also happen at the end of life, and the importance of effective teamwork. So really making sure everybody's on the same song sheet.
Great. And so we're going to talk a lot about dying today. What are Australians dying from mainly, Kim?
Well, these are the leading causes of death that are in front of us now from the Australian Institute of Health and Welfare. So we've got coronary artery disease up top, dementia and Alzheimer's disease, which are life-limiting diseases, cerebrovascular disease, lung cancer and COPD. These are the big killers in Australia.
And given that list, Kim, I guess we're mainly talking about older Australians, is that right?
That's right. So 2 in 3 deaths in Australia occur amongst people aged 75 years or older. So that really, when you see that that statistic there, you want to question yourself and think, how many patients do I see at the moment who are over 65? And could these people be planning for the last phase of their life? Could they be thinking about advanced care directives, or could they be thinking about their place of care when they get older? And then the other question might be really, really great to think about is, how many patients am I seeing that are over the age of 70? And am I, as a clinician, as a nurse or a doctor or an allied health professional, am I identifying their end-of-life phase?
Certainly when we look at the figures for our general practice, most of the patients we see most frequently are over 75. I guess the causes of death change as we go through our lifespan.
That's right. When you look at that, I love this chart, you can really see in the last 3 columns there, that's right, this is where most of the deaths happen between over 75. But you can really see how those causes of death, the leading causes of death, dominate in those age groups.
And looking at that list, Kim, some of those deaths are quite sudden, particularly for the younger suicide and accidental poisoning, sudden unexpected deaths, but others in the older people perhaps are more predictable. Are there some common patterns that you've found?
That's right. That's right. So they're expected. These people are living with a life-limiting illness that we're expecting their death. So all the more reason for us in these leading causes of death to, when we're delivering services to patients, to engage in conversations. And patterns of dying have become really very helpful schemas to help us think about a trajectory of somebody's illness. And you can see in the first image on the top there, which depicts mainly cancer. So we've got function on one side and time down the bottom. And you can see that people with cancer have really quite good functioning, and it's really towards the very end of their life that their function declines quite rapidly to death. In contrast to that, heart and lung failure or organ failure, there is a very gradual and steady decline that's punctuated with acute exacerbation of their illness, which may lead them into ICU, and their tablets are tinkered around. We're very, very good at helping people recover from exacerbations of heart disease or COPD. And people recover, but they don't actually get back to where they were functioning before. And so gradually over time, they decline. However, sometime in one of those acute exacerbations, it can be a bit more unpredictable, death will occur. And then finally, the lower image is frailty and dementia, and you can see the gradual decline of function over some time.
Kim, I love that term, prolonged dwindling.
Yeah, the dwindling.
Running out of gas, we might say. So we know that most people want to die at home. Is that what happens?
No, unfortunately they don't. And in Australia we know that, the majority of people die in hospitals, and that's because conversations don't happen and people don't plan for the end of their lives. And a physical crisis will happen at home and an ambulance is called, and then once you go into a hospital door in the ED, you are we're very good at treating people's ill health, and you get on the treatment, we call it the escalator to ICU or the treatment treadmill, and it's very hard then to backtrack from that.
So it would be helpful if we could identify people at particular risk of dying soon. I guess that's part of the framework you've developed.
That's right. I mean, we've put together this education package, and identifying end of life is core. And patients and families are often unprepared for the healthcare choices at the end of life. And so if healthcare professionals don't mention this, it can go undiscussed. And so knowing trajectories of decline, the patterns of ill health and how they progress over time, can be really helpful in starting conversations with patients and families. So you can start saying, your illness is not going to get better and there will be a decline over the years. How would you like to manage that? Because we can plan for this decline. And I think one of the really big things is to be prepared as a clinician for unexpected questions from patients. So patients might say to you as a GP, oh gosh, when I was in hospital I thought I was going to die, I felt so sick. And then that invites you to discuss, really, you thought you were going to die, let's talk about that. That sounds, really profound. Tell me more about what was going on for you and what became important at that time. So using triggers is another way that we can identify patients who've got unmet needs, or that you can plan ahead to actually anticipate those end-of-life needs.
Yes, I'm often surprised, Kim, how often that even when a death is predictable, how little the families have discussed dying and what's going to happen after death, and whether cremation or burial.
Yeah.
People don't routinely talk about these issues. It must not be part of our culture.
It isn't, and we need to discuss it around dining rooms, Tony. You know, we need to start talking about even about a will. Very few Australians have a will. So I think there's a lot of, a lot of improvement to be done. So to help clinicians, I think, you know, there's a couple of things that we can look at. A surprise question we'll talk about in a minute, and the SPICT, which is a tool we'll talk about in a minute. But anyone over the age of 65, you could say, you're actually quite, that's a bit of a typo there, you're actually quite well now, but have you thought about if you became too sick to speak for yourself, who would you like to speak for you? And if you've spoken to that person. So I think, you know, you can make a hypothetical out of it that gets people thinking about the future.
Yes, certainly we do. You know, we commonly in general practice are doing 75-year-old health assessments. To include that question routinely in our health assessment would be a good system change. So you talked about the SPICT tool. What does that mean, Kim?
Yeah, we go on to the next. It's a tool that's been developed. It's the Supportive and Palliative Care Indicators tool to help identify deteriorating health and in a patient. So you can then have your antennas up to maybe this person is progressing over, you know, 6 to 12 months, that they may need conversations, plans, and some end-of-life care planning. So you can see there, they're very performance-based, so it's all about function. So not being able to do things for themselves, they're dependent on others, weight loss, troublesome symptoms, and you know, I think they can be really good ways to think, oh, we need to get on top of this. I think a lot of healthcare workers would think, oh, we can fix this, whatever's going on for that person. But really it might be a way to think, well, maybe we should be thinking about an end-of-life care plan.
And there's a website there, Kim, the www.spict.org.uk for practices that want to include those questions as part of their health assessment.
Yeah. Yep, you sure can. And if you register, you get all the updates as well.
And then there's a surprise question.
That's right, and the evidence is growing that these type of questions can be quite useful, and it really just goes on your clinical, all those years of clinical expertise that we all have, and it's asking, would you be surprised if this patient died in the next 12 months? And if your answer to that is no, I wouldn't be surprised, then that might be a trigger for you to start thinking that the patient who you're delivering service to might require a conversation and some planning.
So we need to be having conversations.
Yes, absolutely, absolutely. So have a conversation, even with patients who are quite well. So that could be talking about the future and as a hypothesis. If you were to become ill, have you thought about what you would like? You know, we can't, I wish we could cure this illness, but we can't make it go away, and it will affect your health as the years go on. And especially with patients who are living with chronic complex conditions and the ones that are the leading causes of death. But the really big thing to know is there's no one right way to open up a conversation about the future. And it's best to be as honest as you can be about end of life, and to remember that we will all die, and it's a great opportunity if we as healthcare professionals can engage in these conversations.
Yes, all of my patients die, certainly, and the longer I'm in practice, the more I realise that, and I'm inspired now from your comments, Kim, to look for trigger points, but also to start having these conversations routinely at different stages in our patient journey. We're never sure what's going to happen, are we?
No, and I think that's the big thing. We can identify patients at the end of life, easy in retrospect, harder prospectively, but I think it's still really worth going through that process and assessing their need and to plan their care. And it will be undoubtedly be uncertain, but I think that's a great way of discussing that with patients as well. You know, I wish I knew what was going to happen into the future, but I don't know. But I think, you know, to talk about what usually happens for the group of people that have your illness, we can then maybe get an idea of what's going to happen for you. And let's plan for that.
So we're beginning to talk now about how that conversation flows and what we talk about. Kim, there are some principles of end-of-life communication that you've established.
That's right, and I think that you know, most patients want the truth about their prognosis, and there's some really interesting research by Nicholas Christakos in the US, who's found that clinicians are often overly optimistic when they're thinking of prognosis, but most patients want the truth. And a big thing is you will not harm your patient by offering to talk. So you can always say, can we talk about the issue of planning for the future, for the end of your life? And if they say no, then you don't have to carry forward. But if they say yes, then you can keep going. Anxiety is really normal for clinicians, for doctors, nurses. You know, these are hard conversations to have. And a big thing is patients may have goals and priorities besides living longer. So if you have a discussion about poor prognosis or the dwindling, Tony, that you like, the dwindling, you might say to a patient, well, you're walking quite well at the moment. You're able to function quite well. Is there a cruise you'd like to go on? Is there a trip have you caught up with your family? So there's other priorities apart from living longer, and I think that patient goals and priorities empowers you to provide better care.
Yes, so if we find out what our patients' goals and priorities are, we have a chance of meeting them. I think you've experienced some examples of met and unmet patient priorities.
That's right. Now here's Joan, and Joan's got COPD. She's had repeated pneumonia, and she lands up in hospital in January 2016. And people don't identify that she's at the end of her life or that she's got a leading cause of death in our country. And no end-of-life conversation happens with Joan. And Joan goes home feeling pretty good she's out of hospital, but she's really not back to where she was before. She doesn't realise she's in the last stage of her life because everybody in hospital told her how well she was doing, that she recovered. Then, of course, she gets a relapse, and in July 2016, she ends up back in hospital with pneumonia, and she arrests, and a MET call happens, but she dies being resuscitated. So there's no end-of-life planning for Joan.
And we could do that better.
We could. So here she is again, the same diagnosis, but when she goes into hospital in January, and this could have happened in the community, the medical registrar uses a trigger and says, I think things are changing for you, Joan. You're not as well as you were 6 months ago. You've had repeated chest infections, and this is a sign that, you know, that things aren't improving, and go on to have a conversation about end-of-life care. Joan organises her preferences with her daughter once she's home. She talks to her GP about home death. She has an opportunity to rehome her dog and go through her things and give things to her granddaughters. And then in July, she decides she doesn't want to go back to the ED, she doesn't want to go back to ICU, and she doesn't want to go back to hospital. And with the support of community nurses, GP and many, many others, a home death is planned. So that's what we can imagine could happen.
I can see that by giving Joan may not have even realised she had permission to not go to hospital. She might have thought that she has to go to hospital. So having the conversation has allowed her to work out It's a really person-centered approach, Kim, that you're talking
Yes,
about,
that's
looking at
right.
the whole person, and very little of what you're talking about is disease-specific. When we're looking at decline, it's more whole person issues.
That's right. And I think, you know, we need to twist our words and change our mindset to ask not what's the matter with you, is it COPD, is it heart disease, but what matters to you? Joan, what would you like? This is what your body is going through. Now tell me as a person what you would prefer in the time that you have left, and let's make sure you live now, not live in the ED, not live in ICU, but let's make sure you live to the best that you can in the place that you wish to be.
Kim, that's fantastic. So I think we realise that we need to be planning for end-of-life conversations, we need to have triggers, we need to expect it, we need to normalise it. Can you tell us a bit more about the actual conversations, how one manages that rather anxiety-provoking conversation?
Yeah, look, they can be, and they might not be, but I think we all have a different skill set when it comes to communication, and often it's something that we haven't learnt in undergraduate training. We learn all about catheters and IV tubings and whole sort of technical things, but we haven't had that basic training. So I think it's really important to hold a mirror up to yourself and be honest and think, what challenges me in discussing end-of-life issues with patients? Am I afraid to say the words dying, or am I really hesitant when patients say, what will happen to me? Do I cheer them along and say, oh, you'll be right, Joan, you're doing really well, we'll get you home again, you'll get out to the letterbox and back in again, you'll be fine. And then you can choose one thing if it's about discussing prognosis, even if it's about just using the word dying, if it's about entering into discussions about shared preferences. I think it's really important to listen more than you talk, to let the patient express their concerns. And the other thing I think is really hard for healthcare professionals is to be comfortable with uncertainty. So to be comfortable with saying, look, I don't know exactly when you will die, and nobody can tell you that, but we would like to support you through this last phase of your life.
And so by undergoing this reflective process and listening to the patient, we can come up with some shared goals.
That's right, and I think shared goals and are agreed, and they're really important because they really focus on what matters to the patient, and they need to change over time and be reassessed as necessary. But it can include all types of care, medical interventions, place of care, types of nutrition, and patient values. So, you know, we really need to not place what we would wish for a particular patient, for Joan, for example. And that, I think, is quite a challenge for many healthcare professionals. But we do need to think about the patient and their values.
Fantastic. So that's fantastic, Kim. So you and your team have done a lot of work on training us providers in developing these skills and come up with a number of both training modules and resources and downloads that we can access and use to improve our end-of-life care.
That's right, Tony. And so everything that we've talked about and a lot more has been developed into evidence-based free e-learning that has been peer-reviewed by about 45 clinicians around the country. So this is quality free e-learning that's been generously provided by the Department of Health, and lots of resources there for practices and services that you can download for free. And these are the e-learning topics: dying, a normal part of life, patient-centered communication, recognising end of life, goals of care, teamwork, and knowing what to do when things aren't going well, because suffering can happen at the end of life. and there are ways of responding, and to really be sure that your service or your own practice is thinking of all the options.
That's great. So some of those resources we've made available in the participants will find them in the materials section of the control panel. There's 2 PDFs to download. One has this information, end of life essentials, and about the project and how to access it. And the other, I think, is a list of other resources you've collected for us, Kim.
That's right. I think, yep, Tony, there's a whole lot of there's a community groundswell happening about end-of-life care that I think people will find really interesting, that's happening outside of health. So I've included a couple of really quality resources there for people as well.
Well, it'll be fantastic and interesting to see what our participating practices come up with as far as improving the quality around the quality improvement process around end-of-life care. We'll be keen to see your improvement ideas as members of the QI community, and we can, just as Kim has generously shared her resources, we can share one with the other. Fantastic, Kim. So thank you for bringing us your expertise and sharing those resources. I've certainly had some ideas that I can take back to my own practice, and I'm sure on behalf of the other participants in the webinar, they will also be able to improve their processes for end-of-life care. Thank you, Sarah, QI Community Central. Thank you for everyone who participated. We will see you all next month.